want to just introduce myself and thank you for actually inviting me for this talk. I'm always very happy to actually give talks for the Brahm Centre. I just want to introduce myself again. I am Dr. Siow Wei Ming. I'm actually a consultant orthopedic surgeon in Sengkang Hospital, and I actually specialize in the area of hip and knee reconstruction surgery. That means in the area of hip and knee replacement surgery. So day in, day out, the most common things which I see is actually patients who come in to see me with hip or knee pain. So this is actually literally my bread and butter, and I hope I can actually, during the course of the next 1.5 hours, be able to actually give you a quick intro or a primer on what actually we do in this particular area of this particular set of conditions. I am actually going to break this talk into two parts. One on knee pain specifically in terms of knee arthritis, and another one in terms of hip pain itself. And I'm going to preferentially give it more for knee pain because I actually see more patients with knee pain than I actually see patients with hip pain itself. In a rough ballpark of about 60% more of knee pain, 40% of hip pain. If you all need more information about hip pain, we can actually talk about it more, but potentially it might be during an overtime cloud component to this itself. Okay, I'm just going to share my screen. Just give me a moment. In terms of questions for the talk, I would appreciate if we can actually leave questions to all the way to the end of the talk itself. I do actually give space for questions in between, but it's just for at the most 1 or 2 questions. Okay, so that's the talk for knee pain. I did actually present this talk not too long ago, about 2 years ago, in the Brahm Centre, and it's quite similar to what we did, but maybe a bit more of updates along the way. So it'll still be pertinent, it'll still be interesting for everyone. So knee pain and arthritis. The first thing which I want to declare is to say my conflicts of interest. I have nothing to declare at this moment in time. In terms of disclaimers, the critical thing is to understand that I'm actually giving a general educational talk about this particular topic. Specific procedures and treatment plans are always normally tailored to the patient, and so it can differ according to the individual needs of each patient. I cannot actually give personal one-to-one consultations or personal advice, and for these, please consult your knee surgeon in Singapore. In terms of copyrights, the images and videos which I have used in this talk have been used for educational and non-commercial purposes under the Fair Use Guidelines. Okay, in terms of topics covered for knees, this is actually what I will cover. I think it is important to understand what a normal knee is first like. And I think that is actually something which most people don't really appreciate. And I think it's good to always have a good grounding, because then when you actually look at what's abnormal, then you can see, oh yeah, that's actually a big problem. And also it's good to actually find out what's the various causes of knee arthritis, because certain causes are actually more common than others. And some of them are actually ones in which is can be potentially either mitigated or reduced in incidence by doing certain things, and treatment options then will follow as follow up to that. I will cover 3 different types of surgeries: keyhole surgery for the knee, there is arthroscopic surgery, bone realignment surgery, and with emphasis on total knee replacement surgery, which is normally what most attendees want to ask me to explain more. So I've actually given more emphasis in this particular area. So what is a normal knee? Ultimately, I think we can just break it down into a simple fact that all joints in the body, at least the mobile ones, always have a bone above and a bone below. And in between is actually the joint. And both of them will have a bone ends. And as the bone ends come together, there will need to be actually this protective cushion lining. That means a cartilage which actually prevents the 2 bone ends from touching each other. And this prevents grating, prevents the bone ends from touching each other. And it's this grating which actually causes pain. So cartilage does have a part to play. It is providing this protective function as much as a lining function for the bone. When we talk about the knee itself, then we actually go to more specifics. The top bone is actually the thigh bone, which is the femur, or the bottom bone is actually the shin bone, which is tibia. Of course, we shouldn't forget that it's not only just two bones, but there's actually an additional bone in front, the ones that you can feel, which is actually a kneecap. That's what we call the patella. So these three bones are what is composed of the knee. And interestingly enough, it actually forms three joints within the knee itself. So there's actually not only one joint, but actually three joints within the knee, or three subcomponents of the knee joint made of these three bones. Regardless, all these bones must always have cartilage covering them, so that nothing gets actually, there's no actually bone versus bone abrasion or grating. Okay? One thing of note though is that sometimes maybe cartilage is also not enough, and when there's too much pressure, it can sometimes fail. So the knee actually, evolution has made in such a way that the knee actually has created additional shock absorbers to fill in all those areas in which has too much pressure. And these shock absorbers help to redistribute out the forces and reduce those forces passing through in too high concentration in the middle itself, and spread it out to the sides, allowing it for movement without undue too much pressure being applied through the area. My best way of thinking about meniscus as a shock absorber is a bit like the Nike Air shoe with that little disc found at the back of the heel. Same concept as well. So this is roughly what a shock absorber is. The meniscus is. It's a C-shaped ring-like structure, roughly the consistency of the nose, and its job is to actually distribute out all the forces through the knee across the entire surface area of that knee joint itself. Okay, if everybody's okay with that, then I would move further. And moving further means telling you more about X-rays and how to actually literally interpret X-rays. So this is what you see normally for X-rays, done when taken from the front. We can see the top bone is actually what you see over here. I'll use my mouse to show it. This is the top bone, or what I call the thigh bone or the femur. This is the bottom bone, or what you call the shin bone, the tibia. In between is this river of black. And this river of black represents all that cartilage / meniscus, that is the shock absorber which we were talking about. So you can see the importance of this black river. This black river is a good indicator telling me whether there's actually any adequate levels of cartilage or meniscus in that particular region of the knee. So this is the inside part of the knee, and this is the outside part of the knee for further referencing. So you can compare it with a cartoon or a picture of it. In this case, it's a bit more difficult when you look at the cartoon. And the reason why is because the cartilage in the knee itself is actually distributed in more areas than you think. Ultimately enough, what we're looking at is actually just this part, which is here. And it's actually in this particular turquoise part of the knee, which is where the meniscus is. This is what I'm most interested in. This thick layer of black in between. This thick layer of black, you can see, is roughly about the same distance, same width on both the inside part and the outside part of this knee. Okay, let's look at the side view. So here's a side profile of side profile X-ray of a knee, and you can see it's roughly about the same. Kneecap, which is the patella, the thigh bone, which is the femur, and the shin bone, which is the tibia. And you can see also roughly, like what I say, the one principle is all these bone ends must be covered with cartilage. And you can see the cartilage is adequate over here, enough until you can see at least a black line. Then some people will say, "Oh, how come this part is actually touching each other?" The reality is that it is not, because if you were to actually look from the front profile, there is this little bone notch, or this little nubbin of bone, which is protruding out, which represents all the attachment of all the various ligaments found within the knee itself. So all these tend to create a little overlap, which is found over here. And that's considered normal. What I'm actually interested in is just this part. This curve and this curve are far apart. There's adequate gap in between. The nubbin, I ignore it. In the slightly different profile, where we actually ask people to actually do a half squat and we do an X-ray, this is a good view of the cartilage of the patella, the kneecap, and how it actually interacts with the thigh bone, the femur. So you can see in the cartoon, this is how we actually take it. And you can see in the left side what we actually expect to see. What we need to see is a thick layer of black still, regardless. And this black is actually representing the cartilage of both the patella, the kneecap, and also the femur, the thigh bone. So I think that's actually a quick run through of what is a normal knee. I can actually stop for questions here, maybe 1 or 2 questions. But otherwise, right, if not, then I'll continue on. I'll give about 10 seconds. Okay. If there's no questions, then the next step is actually talking about how is it that actually pain can develop. Well, I think it's important to think of, let's try to keep it simple. And let's think of the knee joint like a hinge. And over time, sometimes, right, the hinges can actually tend to start creating sound, not be able to open and close the door itself easily, and what's not. And so, the same thing for the knee. This is actually quite a common thing, and most people who tend to see me tend to actually complain of mainly knee pain than hip pain or other areas of pain. And it's actually really, really down to why is it painful? And that's what we're going to explore in this next section. So, of course, right, in simple terms, it's like that. But in reality, it's a bit more like that. Where we're talking about the ideas of wear and tear occurring in the knee joint together with that causing pain. So why does this happen? Well, one of the primary causes of knee pain can be also to do with injury. Let's say like trauma, fractures in the bone, or if not, maybe even a tear. That means a break in that shock absorber, or maybe even just a lobang, a hole being cut out from the cartilage. All these things can lead on to the surface of the knee joint being uneven, being almost like what I see on the right, a cheese grater. And you can imagine over time, as you actually have a cheese grater in the knee joint itself, that is actually going to cause problems. So that actually can cause a lot of rough, uneven surfaces, which lead on to quite fast, accelerated wear and tear within the knee joint itself. Loose bodies are ones in which little bits of bone or cartilage get released off. And the problem is that they actually tend to wreak havoc within the knee by actually causing a jamming component inside the joint. I always see the knee joint like an engine, and a loose body is almost like there being gears within the engine, where one of these gears, the teeth has broken off, and unfortunately has gotten lodged between other gears. That's the idea of loose body. In terms of other causes of arthritis, one other potential cause can also be to do with crystal formation by certain special types of salts. One of them is uric acid, another one is calcium. What these tend to have to do is that over specific types of environment, there is, for example, a very hot environment where a person is dehydrated, not drinking enough water, but at the same time eating a lot of purine-rich food. Examples are like maybe peanuts, a lot of red wine, or red meat, or some would say even durian, or hemi, or bakute, or something along those lines, or maybe even actually like anything which, even broccoli can actually cause this. Sometimes it causes increase in concentration of uric acid within the body. And when suddenly you get exposed to a cold environment, especially the feet and the toes and the knees, that is an environment where you have a concentrated saline environment of uric acid with a cold, which is cold, that causes all these crystals to want to precipitate. And they tend to precipitate in areas where there's a bit of roughness, because you do need to have actually some level of a little seed for these crystals to grow. And when they grow into these small little sharp little crystals, which tend to actually irritate the joint lining. And it's the irritation of joint lining which then causes joint pain. So calcium can also cause it, but not everybody gets it. Only a very, very specific subset of people tend to get this other type of this particular type of calcium crystal related joint pain. That is called pseudo gout, if you are interested. Okay. Now these, most of the time, they can actually be treated with medication, diet control, and also avoidance of certain things, and also a lot of hydration. Of course, one more potential cause is autoimmune disease. What does that mean? It means the body is actually attacking oneself. So the battle lines, the battlefront, is actually somewhere in the bloodstream, where the body is actually creating something. And at the same time, another part of the body, that is actually the immune system, is attacking that component. So when the immune system, which is the antibody, attacks that thing which the body is creating in the bloodstream, a lot of it's actually like a big waging war in the body itself. And what happens is that there's going to be a lot of collateral damage. And one of the collateral damage is at the knee joint. Why? Because all these antigens and antibodies tend to float around in the body. They clump together, and eventually they actually end up in places which have a lot of blood supply, or at least slow blood supply. And one of these areas is at the joint lining. So when they accumulate there, it causes a lot of inflammation, and the joint lining gets really red, hot, and angry. And eventually, the joint lining literally eats up the cartilage in the bone and the bone itself. So one good example of autoimmune disease is rheumatoid arthritis. However, there's of course more different autoimmune diseases possible, but that's one of the more common ones. So just think of it like a big battlefront in the body, with one of the front lines being actually in the joint. And of course, last but not least, but the most common of all, is wear and tear. So the way I see it is a bit like what you see over here, between the left and the right of this tire, one being actually brand new and the one actually being totally worn out. The honest truth is that we do actually have a particular limited lifespan for our cartilage. Evolutionary speaking, we are actually designed to last about, to actually, our body is actually designed, to actually last till reproduction. And then post-reproduction, then things tend to start to go awry. But I mean, it's this thing which tends to happen for anybody, everyone, whether actually it's humans or any other plants or animals or anything of that note. So this is actually one of those things which occurs to us, where over time, things which are actually designed for up to a certain level of use tend to start to undergo wear and tear. And this wear and tear is dependent on a particular wear rate itself. Where, to me, in my mind, I simplify it, wear rate is a function of how much load that area is receiving with how many times that thing is, that particular joint is being used. So one good example of load is, for example, how heavy we are, what's our body mass index. Another idea of load is whether we actually need to carry a lot of things to and from commuting, or whether during our actual job itself, we actually have to carry a lot of things too. Cycles, in terms of the number of times we use the knee, it's really, really dependent on most probably our job, and also what we do in daily life. So those who actually need to stand a lot, or climb stairs a lot, or squat down a lot, or need to actually walk or go up and down the slopes a lot, these people tend to actually receive a lot more stress. What's the most stressful types of activities for the knee itself? Well, most of them involve squatting, getting up, climbing stairs. These are actually particular things of note. It's quite common and not unusual for us to actually see teachers come in with knee arthritis. Why? Because they actually have to climb up and down stairs a lot. At least minimum three flights of stairs frequently. Then in terms of squatting, standing up, it might also be related to activity. Sometimes repetition in that can actually cause quite a lot of wear and tear. I mean, I can't say don't do it, but in the end of the day, it's the question of after how long a period of time, then when do things start to actually undergo that level of mechanical wear and tear? Now, that is actually the key. So regardless of all these, I think trauma, infection, injury, sharp crystals, autoimmune disease, and overuse and aging, all these are different causes of knee arthritis. So what gives then? What actually happens after that? So no matter what, all these causes of arthritis tend to cause the cartilage to soften and fray. And once it softens and frays, it breaks down. And when it breaks down, the problem is that the bone ends start to get exposed. And once they get exposed, that's when they start to grate. And the grating of the bones lead on to eventual inflammation, which represents itself by a triple combination of pain, increasing stiffness, and swelling. With time, with enough grating of bone, especially in these areas, what happens is that there could be the opportunity where the bone ends start to grind off to dust, literally. And that's when you tend to see increasing deformity occurring. So it might start off like this, and it might occur like this. So for everybody, it might be that, you might see people with legs just straight when they are, for the longest time. But over time, as a person age and as this effect of arthritis occurs, then you might see the legs start getting bowed. Now, this is the reason why the legs get bowed, because of eventual progressive wear and tear of the bone ends as they get exposed. The protective cushion of the cartilage is gone. And with time, this deformity can also cause problems, because with increasing deformity leads on to increasing amounts of stress passing through this particular area in comparison to this area. So originally, maybe we have only about 50-50. Then with time, as it gets more and more deformed here, it can go on to 75-25. Then eventually, at its worst state, 100% of the body weight passes through a very limited portion over here compared to here. You can imagine this actually is a runaway effect. With time, right, this can actually get worse and worse and worse. Not to say that everybody gets it. It's really down to that wear rate component itself, the amount of load and number of cycles. So what's the manifestation of all of these? Well, maybe you might have a person might have difficulty trying to do these specific activities like squatting, kneeling down, going downstairs, climbing upstairs, then walking. Other times, right, it might be also to do with this concept of gel phenomenon, where a person complains of stiffness and pain, especially after a period of rest. One example is like in the middle of the night, sleeping and then getting up to go to the toilet, or waking up in the morning itself after a good rest, or maybe even a meal, while sitting down for a meal and trying to get up from the chair. It's very difficult to get up in that first few minutes to seconds. And the reason why is because during this period, the body is actually having a bit of inflammation. When you rest, it says, aha, you have essentially switched off the TV and it's gone into standby mode. Now it's time for the TV to download the new firmware to update itself and to actually upgrade itself. Same idea here. In this case, you are falling asleep or you have not used your knee. The joint, which is inflamed, says, I want to go into repair mode. So in order to undergo repair, it has to do inflammation. And inflammation attracts water, attracts swelling, and that leads on to all this feeling of stiffness, especially when you get out from this repair mode. You're going from standby mode to active mode, shall we say. That's when you feel the effects of that gel phenomenon. With time, things can start getting a bit difficult in terms of mobilizing. And that's when people start to use furniture on the walls or the banisters as a form of support. Eventually, a cane, a walking stick would be a good idea. Maybe a walking frame, okay, because there's a four-legged frame. Sometimes it might be even a wheelchair at times, or maybe with some external help. Regardless of all these, what happens eventually is that there might be some effect to quality of life. So one example is like marketing, driving, commuting, doing chores or toileting or praying even, or sleeping. I think sleep is actually a very, very important factor. If there's actually pain enough that it actually affects sleep, any little micromotion in the knee causes pain, which then wakes a person up, then you know the quality of life is pretty affected. That all these things I ask my patients, and from there I have a rough idea on how is actually the knee, how is it that they are faring with the knee itself. So deformity is one in which it's quite apparent when you see it outright. Everybody starts off this way, or at least the majority of people starts off this way. Some people might still have it slightly bowed or slightly not. It's just everybody has slight differences in terms of their morphology, in terms of their shape of their knees. But with time, with wear, the typical pattern is that the inside parts, which is where the force of the body is running through the most, tend to wear out faster. And with that, that's when you start seeing this particular part, this nice thick black river, which I said previously, starts to taper off and disappear. And the reason why it disappears is because that area is slowly grinding away, slowly wearing out, until literally it's bone versus bone action. With that, then you might start seeing this bow-leggedness starting to develop. So if you were to have seen anybody with straight legs in the past and bow legs now, this likely it. This takes years, so it might not be as fast as you, so you might not even notice it until months to years later, or maybe you might see it in pictures, okay, but of yourself in the past, or pictures of your loved ones in the past. But this one takes time. Okay, but the reason why is the same. Okay? If it occurs on both sides, it's easy to walk. However, if it occurs on one side and the other side is fine, then you also have additional problems too. One of them is that you might actually have shortened leg, not because the leg is short, but because it's bent, slightly curved to one side. And because of that shortening of the leg, it tends to cause the pelvis, the top part itself, to actually slant to one side. And this slanting of the pelvis tends to cause the spine to curve to one direction. There lies the problem. That causes a lot of stress through one part of the spine and not the other part. So that can also cause accelerated wear and tear of the spine. And eventually, because of all this shortness of leg, unequal leg lengths, and different pain from here, there's an increased tendency for falls. And falls doesn't cause problems with the knee, but causes a risk of fracture. So I would call this the triple whammy of one of the consequences of long-term knee arthritis. Okay, so this is actually the component for treatment options for the knee. I mean, not treatment options, for in terms of causes of knee pain and the manifestations of it. Okay, let me just go through then with treatment options. Now, treatment options, we should be systemic and comprehensive. And the idea is that we want to make sure that we actually make sure we diagnose properly, find out what the problem is, and then thereafter that give and deliver treatment in a graduated, progressive way. Where if this one doesn't work, then we can try other things. But eventually, when push comes to shove, what's the last step? That's the thing which we will then discuss here. So in this case, first thing which I'll do is make sure I exclude other causes, like pain coming from somewhere else, which can mimic a knee pain, or autoimmune or gout, what we were talking about previously, the different causes of knee arthritis, because those can be treated with medication first. And then thereafter that, we've got a whole list of other treatment options, which I'll go in detail later on, together with surgery. So excluding a spine or hip cause for knee pain is very, very important, because ultimately we need to know, and we need to actually know what the real diagnosis is. Then at least the options can be given for that area, because if not, you'll be just, it will be just barking up the wrong tree and doing treatments which maybe might not actually really improve anything at all. Or interestingly enough, it might also sometimes be combined. That means both real indeed knee arthritis with real indeed back problems, which then can cause overlap of pain in that particular region itself. So in this case, the important thing to understand is hip pain, although it does affect the knee, which is normally the front part of the knee, it also tends to also cause pain in the region of the groin and the thigh, in the front parts of the groin and the thigh. Knee pain is interesting. It tends to just stay in the knee. You use your hand and you put it on your knee. That's roughly the rough area where you can actually potentially have pain, where the pain actually comes from the knee itself. Anything else from a hand spans away from the knee must be coming from somewhere else or some other thing. So if it's from the groin or the thigh, and especially in the front, think of hip pain. If it is pain in the buttock, in the back of the thigh, in the back of the knee, and especially in the calf, with numbness and weakness and tingling sensations, and it affects the foot, or you got electrical shocks to the foot, think of the nerve being pinched at the back. These can mimic knee pain, because they clearly do have a component where the pain actually is actually localized to the knee itself. Okay, in terms of autoimmune conditions and gout, we normally do blood tests, and with the blood test, then we actually can actually treat with medication. It's not to say that everybody receives a blood test, but most times we ask specific questions like, is the pain actually on one side or both sides? Does it flip from one joint to another? Is there actually pain in specific parts of the hand and the feet, more in preference, and then now occasionally the knee? These things make us suspect there being actually gout or autoimmune problem. And especially, most of them also tend to actually present with quite a bit of significant swelling in the knee. Okay, now let's talk about knee arthritis, just general arthritis, wear and tear type of arthritis. The last one, which is the most common one, the one which you see the worn out tires on, the one which we were talking about, wear rates equals to load times cycles. So this is the cycles component, where we're talking about what are the things to avoid. So the knee killers, in my point of view, are usually where a person actually has to climb up or downstairs too much, or has to actually squat and stand up too much too, because these tend to actually cause quite a bit of stress passing through the kneecap and also the rest of the knee joint. Deep squats for long durations of time tend to cause concentrations of stress through very, very specific parts of the knee joint, to such extent that it can actually cause injury to the meniscus. So that's something else to think about. So what to do? In this case, then we flip and do the reverse, where we were advised to actually avoid specific activities like climbing upstairs too much, and especially going downstairs too much. If you have a choice, it might be a good idea to avoid the overhead bridge, or it might be a good idea to avoid the LRT staircase, MRT staircase, and take the lift. If you have a choice, if you have no choice, then at least you might want to actually try your best to actually avoid going downstairs as much as possible. Going up is still okay, but it's the going down part is the knee killer, because it's actually 3 times the amount of stress passing through the knee while going down compared to going up. Of course, avoid this particular machine, the stepper in the gym. Don't use it, okay, at all costs. Aerobics, you can consider just normal walking long distances, but also avoid doing what we call using a stepper in terms of aerobic steps, or using that normal step itself. And nowadays, people tend to like to do high impact interval training or lunges. These or Zumba. These might not be a good idea, especially if there's any wear and tear of the knee joint. It's a bit simplified the way I say it, but it's roughly that I say it more to most people in terms of how to avoid it. In terms of squats, best is just don't squat if you can. But let's say if we really have to squat for a reason, then the best alternative might be actually to get a low stool and to sit on a low stool. I think that actually resolves a lot of problems. And nowadays, we actually tend to have pretty special collapsible stools of various heights, which even my dad has actually bought. And he says it's actually pretty useful. Him actually also having arthritis in his knee. In the end of the day, anything which actually helps to support the knee while trying to do a particular activity, if you can offload that stress, that helps to relieve the pain and reduce the chance of the bone touching the bone, causing inflammation. Of course, if you cannot squat, then you might want to buy one of these things. And if you ever need to carry any heavy loads, remember it's the wear rate equals to load times cycles. Cycles is what we're talking about just now. Now it's the load. You might want to use one of these things. This one maybe might be useful, especially for those who are living in HDB and need to actually go upstairs for some particular estates with the triple wheeler over here. Even actually, this one can be used day to day for normal activities. So I think that you just need to find it. Okay, losing weight does help. Okay, and it helps quite a lot, especially if a person's body mass index is more than 30. Above 30, the body is just not designed to actually withstand prolonged periods of force with a body mass index of 30, where BMI is equals to the weight divided by the height in meters divided by the height in meters again. Okay, so that's actually the BMI. Ultimately enough, by losing even 10 kg of weight, that's actually 30 kg less of force passing through, especially the kneecap of the knee, because of it's just down to the mechanics of the area. So we do know that actually losing weight helps quite significantly. Let's say everybody then asks me, how do you exercise then? I can't do all these things. I used to exercise by doing lunges, all these ideas itself. So I would say that try first with stationary bike cycling, where stationary bike cycling is one in which we are talking about getting a bicycle with the seat as high as possible until your toes are just barely touching the floor, such that when you actually use the bicycle, you don't overbend your knees. So you can see the subtle differences between the left and the right. I won't go more further. You can use swimming as another one. And if you don't know how to swim, then ultimately acrobics, that means being in the swimming pool and running around in the swimming pool can help, because we are basing on the Archimedes principle of buoyancy. It helps to reduce the amount of load passing through the knee joint. Some people do ask about this. I say no harm. This is more of physiotherapy than real exercise, because ultimately enough, you're not really expending calories while doing this, but it does help to actually increase the range of motion of the knee. And you can just buy the cheapest one. You don't need to buy a very, very complex one. Walking sticks and all these walking aids, these are some varieties. I think the general gist is just don't use umbrella, because umbrella is really not designed as a walking aid. The umbrella is actually a hollow tube of metal. It's designed to be not that heavy, so it's likely that it's actually not very, very, very stable, and it tends to break. And when this breaks, you fall down, you will break. Daiso sells quite good walking sticks, surprisingly enough, and they sell at different sizes and everything. So I think that's actually quite easily accessible. Okay, I do recommend everybody just go and get one of these, or at least buy a few and try it out. Because it's not that expensive nowadays anyway. Of course, right, the problem is aesthetics. And this might be something interesting because this one is something which can be hidden away and used only when really, really required. Okay, physiotherapy helps to increase range of motion. It strengthens weak muscles. It helps to distribute whatever joint fluid is left in the knee. So it's a bit like trying to actually, the best way I can think of in terms of the analogy for physiotherapy is just like if you have a really, really rusty door hinge which is seized up and you can't even open the door itself. First, you open the door, then you start to actually shake it a bit, or a few times. And as you actually or the hinge, it tends to actually increase in its movement. And it can open larger and greater distances itself until it can fully open fully. So that's the idea of physiotherapy. It helps to stretch things out, which are already in existence very, very tight. Also, at the same time, it's just bringing in the natural singer oil, which you are generating in your joint. Painkillers are painkillers. These are some which can be applied on the skin. Most times, most people tend to actually like to use the one on the bottom right. Ultimately, the key for the bottom right is don't keep it there for too long a period of time, not more than 4 to 6 hours, or else it does tend to cause skin irritation. And eventually, people think that there's actually going to be allergic reaction, while in actual fact, it's more of just eczema from irritation for adhesives. Medication is medication. Some are good, some are better. All of them do have some side effects, no matter what. Some can cause long-term kidney impairment, heart impairment. Some also can cause ulcers to form in the stomach. And a lot of people are actually allergic to some of these medications. And how about glucosamine and chondroitin and all these things? Well, the honest truth is that they're useful. They do provide a role, but not how you think. Its job is there not to actually create to cause a eventual return to a nice thick black layer of cartilage on the X-ray. Its job is to lubricate. This is its function. So you can imagine as you take the medication, it does increase the amount of joint fluid lubrication in the area. But eventually, just like how singer oil is applied to a creaky joint and the joint fluid the oil starts to evaporate, the creaky joint might still actually come about again. And the reason why is because no matter how much oil is being applied into this area, the hinge stays rusty. It's just that it is a rusty, well-lubricated joint instead of a rusty, non-lubricated joint. And there lies the same concept for injections. So injections can come towards both a combination of giving steroids and giving gel, which is actually just a type of natural joint fluid which is found within the knee. They do actually have a role and they help to actually lubricate the knee. However, it's the same concept here. You're actually just applying singer oil to a rusty knee joint. So once all these things are exercised, and once things start to go downhill even after that, when I say downhill, that means roughly speaking, all these things being affected, especially the bottom point in terms of quality of life, that's when we start thinking along the lines of surgery. Normally, I break it down into decision making for surgery into 3 parts. One is, does the knee pain affect my work, my job? Because if it affects your job, then you can't really work much, and salary is affected, or a person might be forced into early retirement. Number 2, does the knee pain cause my impairment for wanting to do what I want to do? Hobbies, travel, sports. Does the knee pain affects my activities of daily life? That means things which I normally do, like chores, going to the toilet, taking care of myself. And eventually, does a knee pain affects my quality of life? Example is like sleep. Okay? So when you amalgamate all these things, then it's then balanced with the risk of surgery. And the risk of surgery with the risk of anesthesia combined, and then it's actually a balancing act between these two, which one is beneficial. So in terms of surgery itself, there are 3 types. One of them is knee replacement surgery. Another one is bone realignment surgery, which I would give a quick intro. and also then keyhole surgery to wash, clean, and trim. Okay, keyhole surgery, the honest truth, at this age, I would say it is more to do with essentially just like an engine flush for a very old car engine. I mean, nowadays, all our cars are actually 10 years or younger because of COE. But in the good old days, when there's no COE, we have seen, I mean, you'll be able to see maybe across the causeway, engines which have been running for 30 or 40 years. Those would be rusty, cranky, a few holes here and there. They still run, but clearly, right, they might need an engine flush. Engine flush does work to some level. It does help to actually clean up whatever is inside. However, the honest truth is that all these, whether it's trimming cartilage or trimming the torn out meniscus, they're all essentially something equivalent to this. Because what it's essentially doing is somebody using the best way of saying it is using a sandpaper and sandpapering off all the rust on the surface of this metal. Or maybe the best way of saying it is more a grinder, okay, to grind off all the rust. But it's actually not really that part which is important, it's the inside part which is important. And you can't really do that. So ultimately enough, I see it as just adding single oil to the joint. Eventually, over time, the problem will still persist and it will still progress. But maybe what is happening over here is that with keyhole surgery, you can actually kick the can down to a later date for an eventual procedure, final procedure down the line. Knee replacement surgery is the other option. Where knee replacement surgery is where we actually trim away all the rough and worn out areas, and ultimately enough, we recreate the knee joint using a combination of metal and plastic, where it is metal on top, metal below, and plastic in between. Now, this combination, right, helps to prevent the two bones from ever touching each other, and that lies the key reason why we do this surgery. Ultimately enough, the pain arose because of the wear of the cartilage and meniscus until the bones touch each other and cause pain. Well, here we are actually recreating the normal alignment of the bone such that they do not touch each other anymore. And when they don't touch each other, that's when all the inflammation settles down. So this is a quick video on this. I'm not too sure whether you all can view it, but let's give it a try. So in this case, we make an incision roughly about 10 to 15 cm, depending on surgeon. And from there, then we actually bring the kneecap to one side. We bend the knee, and after that, we make very controlled cuts, very fine controlled cuts to remove the bone and the cartilage until we get a certain shape. And with that shape, then we cover it with a particular implant, which is normally made of metal, cobalt chrome. Below, we also then do the same thing, and then it's capped with another piece of metal, normally made of titanium. In between is a piece of plastic wedged in between, and that creates the articular surface. The kneecap then is also replaced with plastic. So this metal-plastic combination allows for smooth gliding of the joint, allowing for the bones to actually not touch each other while they still can fulfill the function of bending and straightening. Now, ultimately enough, the metal can last for hundreds of years, but the plastic, that one can last for not too long, maybe about 20 years, 20% chance of 20 years for this plastic to actually fail, such that there's a need to change it. But the way I see it is that I think that's a 20-year problem. Most people who tend to actually have knee arthritis tend to be in their 50s or 60s. So we try to do our surgeries preferably 60 and above, so that this 20-year problem doesn't become an issue. Recovery time from surgery, this one is roughly about 3 to 4 days in hospital, where the first day is doing the operation and resting. Second day is getting up from a sitting position, walking with a physiotherapist. Third day is literally going to the toilet and back using by oneself. And then normally the third or fourth day going home. Nowadays in my practice, it started off with 5 days. I've gone down to 3 days nowadays because most people tend to actually feel a bit bored in the hospital, and they feel quite happy and confident about them being able to take care of themselves while at home. They will be normally seen roughly about 2 weeks later. At that time, it's just to actually have a look at the wounds without the need to actually remove any stitches. Most people will be actually walking into clinic with a walking stick, and during this period, I will ask them to concentrate on knee straightening exercises. From there to 6 weeks, we normally start to throw away the walking stick and focus on bending the knee so as to be able to climb stairs easily. And eventually, at the 3rd month, that's the time when actually independence is gained, at least for that particular knee. And independence is actually a function of both a pain-free knee together with a good strength in the knee, so that there's a reduction in the chance of falls. More often than not, we also advise at the time to, especially if there was a severe arthritis on the other side, to actually consider surgery on the other knee. If both knees are actually quite severely involved and the patient is, or the individual is actually quite young, let's say about 50 to, let's say 60 to 70, without any major medical problems, we sometimes will actually even advise to do both at the same time, so as to actually ensure that it's easier for them to actually rehabilitate. Because it's a bit difficult to actually do one side, if the other knee is actually totally not able to actually put weight onto, then the person is actually literally stuck in bed. So actually doing both sides at the same time helps them to actually get up and go as soon as possible. There are certain risks to surgery. In the interest of time, I'm going to actually just go through in a limited manner. Of course, anesthesia also has some risk. Stroke, lung infection, heart attack, these are some possibilities, roughly about 1 in 100 in a fit and healthy individual. Infection, this is something which we really don't want to happen. We always do it in an ultra clean environment, give antibiotics beforehand. However, like it or not, infections can still occur. So this is roughly about a 1 in 100 to 2 in 100% chance occurrence. Most times it tends to only occur in the skin. However, there could be a small chance that it might go into the knee joint proper itself. If that's the case, sometimes there's a need to open it up, wash it out, and worst come worst, even change the entire thing all over again. Now that is roughly about a 1 in 200 occurrence. In terms of nerves and arteries being accidentally cut, this one I have yet to actually experience it in my practice. However, it's seen in the newspapers and literature, roughly about 1 in 1,000 to about 1 in 5,000 chance. If it occurs, there's the need to actually address it immediately with repair surgery. Now, fractures can occur during surgery, of course, and these fractures are part and parcel of the fact that the bone might be actually pretty osteoporotic, pretty weak. So in these cases, we just recognize that this will occur. We know exactly what to do. Ultimately enough, it involves actually putting longer instruments or longer metal implants in, and that's just converting the surgery and adding on more implants in the process. But it doesn't really change the final outcome of being able to stand and walk as soon as possible. Now, the key thing then is after surgery itself, if dangerous things are done, let's say for example e-scootering, there could be a chance that the metal and plastic won't break with force. It's always going to be the surrounding bone. If there's a fracture and it's around that area and it's unstable, yeah, I think maybe that could be a time when we might actually have to change everything all over again. And the implant wear rates I've discussed previously is roughly about 1% failure at 10 years, 5 to 7% failure of the plastic at 15 years, 20% failure at 20 years, but it's very specific on surgeon and also on implant choices. Ultimately enough, I only choose implants which have been out in the market for at least a period of 10 to 20 years, so that I can at least be confident to know that these implants can actually last a minimum of this amount of time. It's not a good idea to always choose the latest and greatest implants because it's very unpredictable. Sometimes it might actually be one in which eventually it gets recalled for some reason or not. And it has been recalled in the past. So sometimes the latest and greatest might not be the best. What you want, what a person wants is actually a reproducible outcome from that particular implant with a known profile in terms of wear rate itself, which has to be tested, literally stress tested by a whole multitude of different people and different use cases. Okay, blood clots that can occur, we tend to give aspirin to prevent this. I think that's it actually for the knee talk. Let me give you an example. So this is one of my patients. There's quite severe right knee arthritis, and with the patient facing us, you can see that the joint is actually worn out. And ultimately enough, this is actually the procedure which is being done. We actually replace with metal and plastic. Plastic in this case, when you do the X-ray, you can't really see it, and metal is on top and bottom. So ultimately, you can see two things. Number one, definitely the bone is not touching each other anymore. And number two, it's straighter. And there is the solution for this area. Okay, just to gloss over, for those who are young, that means maybe 55 and below, or those who actually want to squat down and kneel, especially Malays who actually want to pray, the full prostration, that's our idea. Or maybe like Buddhists also, or even Christians in terms of religion itself. Ultimately enough, there's actually another alternative, but this alternative is very, very specific, only for those who have very specific levels of arthritis in only one part of the knee, and not involving other parts of the knee. That is the inside part of the knee, sparing the kneecap and the outside part of the knee. What can be done is actually what we call a bone realignment procedure, where a controlled cut, essentially a controlled fracture, is done to the bone and is jacked up and eventually held with a plate with screws. And when that is done, what happens is that all the force which normally passes through the inside part of the knee, remember that part of that deformity component that we're talking about over here, deformity causing this runaway effect. Well, that gets all mitigated and all changed subsequently by this particular procedure, because the whole idea of this procedure is to literally offload and transfer the stress to the other side. It allows for running and jogging, and people can squat. This is very popular in Korea and Japan, because that's the land of tatami mats, where people tend to sleep on the floor. So they do need to actually squat down and stand up every day. Okay. One thing to understand is that it just doesn't mean that everything is fully cured, because ultimately what happens is that this area is worn out. After surgery, this area still remains worn out, but the forces all go to the normal area. Eventually, maybe the normal area might still go. That's roughly about 10 to 20 years time, 20%, 30% chance. At that time, if that really occurs, then maybe a knee replacement. That's much easier than doing a revision knee replacement. Okay. A partial one, I think I'll just skip for time. Yeah, I think that's about it actually. That's my summary for the knee talk. So in summary, I talked about what a normal knee joint is, what are the causes of knee arthritis, what are the treatment options for them, and what are the different types of surgery which are possible for the majority of people. There still are other types of treatment options. However, most of them, let's say for example, specific types of injections, biological type of methods, PRP, biological type of augmentation. These are all meant more for the spots, the younger age group, the ones who have very focal arthritic changes in the knee due to injury than anything else, and not due to wear and tear. And the reason why is because wear and tear, it tends to be of a larger area, which makes all these type of augmentation type of strategies a bit more difficult. Okay, so that's it for this particular talk. I can entertain one or two questions over here. So,
thank you, Dr. Siow. We have 25 questions. Would you like to look through
maybe
and
let's
see?
just go through one. Yeah, let's go through them first. Okay. Will AOC, okay, let me just answer one by one. Okay, from I'm not too sure whether I pronounced it correctly. Peggy Tan. Will ACL tear lead to knee arthritis? Is there any therapy that can help to elevate the situation? Now, it depends on when is this ACL tear ultimately enough. We do know that actually with ACL tear, over a long period of time, that means we're talking about 20, 30 years, that it tends to actually cause a slight change in terms of the movement of the knee. And this change in movement of the knee leads on to very, very specific types of wear and tear occurring in the knee joint itself. Apart from this, also, you must understand that the ACL tends to stabilize the knee. So by the fact that ACL is torn, it actually destabilizes it. So slightly more unstable knee causes slightly different loads, slightly more unstable loads being applied through the knee joint, roughly. And that leads on to faster wear rates. So that's when you start seeing the effects of increased chance of meniscal tears, especially on the inside part of the knee, together with an increased risk of arthritis occurring. Is it actually saying that everybody will get it? No, not really true. Because why? A lot of people actually tend to compensate very well with just having strong muscles, strong muscle tone. So that helps to actually compensate for all these things. So it's not to say that everybody gets arthritis eventually due to an ACL tear. If you were to put a gun to my head and ask me what's the percentage like, I would say it's roughly about 20-30%. However, the majority of people will not quote that. Yeah. ACLs, they won't heal over time. Okay, and the best way of thinking about it is that it's actually the joint fluid is a fluid which is trying to be very nice and lubricative, and it's trying to prevent the two surfaces from gumming together. So clearly, right, when you actually have a break of something there, there's no glue or anything which can actually heal this area together anymore. In fact, actually, the joint fluid prevents the gluing of these two parts together. And even if it glues up together, it glues up long. It won't glue up short. So when it's long, it's also not very useful. Okay, next. How to maintain strong knees and hips to avoid early onset of pains. Ultimately, I think what's important is don't do continuously one single thing again and again and again with time. What you're trying to do is to do cross training. So let's say, for example, if you are going to climb up 10 stories of steps just to exercise, maybe it's not a good idea. You might want to actually cross train, do different type of exercises. If you are actually running all the time just to actually exercise, maybe it's a good idea to actually do running, jogging, swimming, other sports too at the same time. Just don't do anything everything must be done in moderation. I think that's the best way of saying it. Okay, of course, right, that's different from when people are trying to do it for sports reason itself. That means, let's say, marathon runners, to get the kick of running a marathon. I think in the end of the day, that's something to think about. Okay, it's a lifestyle choice, ultimately enough. Okay, next one. For elderly, does too much walking cause cartilage loss? Now, you need to balance it out, because if you don't walk, your knee would seize up and it will actually get stiff anyway. So it might be a good idea to walk anyway. And it's just how much walking there is and how much of stair climbing up and down stairs there is together with the walking. That's something important. How much squatting there is. So I would say it's just everything in moderation anyway. You need to actually find some way to exercise. Or else I think in this day and age, right, if I say don't walk, I think everybody will go crazy staying, in one position itself and just cycling at home. There's still a need for walking, but I would say in moderation. Is it advisable to cycle? Will it worsen the pain? Asked by Susie Tay. Ultimately enough, cycling is good. No stress passing through the knee. Still again, I would say in moderation. Still again, I would say keep the seat as high as possible, not too low. Why? Because right, a higher seat means that your knees are not overbending too much. No spinning, no standing up and cycling. Okay, because there's a lot of stress through the knee, especially if you have knee pain. Of course, if you want to do spinning, that is a lifestyle choice. Is there any way to delay the deformity or repair? I would say the best thing to note is that not everybody gets arthritis. Yeah, it doesn't mean that everybody will 100% get arthritis. I've seen soldiers who don't have any arthritis at all. You know, even at the at, at quite a old age itself, and they're coming in for something else, hip, for example. You know, but that's a different thing altogether. So I think ultimately enough, there's what you have to just do is just be very mindful of what you're doing in the day-to-day life in terms of squatting, standing up, climbing stairs. Maybe just do it for its purpose, to go from point A to point B instead of exercise. That will help to reduce all these. Exercise, you can always try the gentler ones: cycling, swimming. All these will be better. All right. Okay. Okay. Let me see. Give me examples of how meniscus tears can occur. Twisting injury to the knee, fall, running for a bus. All these things can occur because, let's just say this way. Ultimately enough, right, meniscus might start off with its consistency of the nose. However, as we get older, the meniscus starts actually becoming the consistency of surimi, fish sticks, which we use for Maggie mee. Okay, so that's the problem. If actually you put too much stress through it, it might actually tear anyway. Okay. I have spurs on knee bones. Sorry, I cannot answer personal questions. What is the steps, procedures to seek consultation with Dr. Siow for a diagnosis of knee and hip pains? I would say that I actually practice in restructured health institution that is actually in Sengkang Hospital. You can always seek subsidized care or private care through the various normal means. So, okay, can the knee hurt without feeling pain? I do my clinics on Wednesdays and Thursdays, whole day. Yeah. Monica Kui, can the knee hurt without feeling pain in the back or hip? Or the knee pain is actually caused by back problem? Yes, definitely. That was actually mentioned in the lecture in terms of referred pain from the knee. So back problems can actually cause pain going down the knee from the back. Hip problems cause pain in the knee in the front. What type of screening should we go for to check if our knees are healthy? There's no need to screen. Ultimately enough, this is something which is just, you will know it when you feel it. I think that's the best way of saying it. Yeah. If taking calcium pills, zoledronic acid for osteoporosis, can crystals be formed? No. Hi, I was advised by a physician to do the squat exercise up and down at 30 times once a day. Is this to strengthen the kneecap? So is it correct? This one I would say is best to actually seek is a very, very specific way of doing the squat exercise in such a way so as not to actually damage the knee. So it's very, very, very specific. So I would say best to actually get professional advice through either a physiotherapist or a physician. Anonymous attendee, sciatic nerve will cause knee pain? Yes, it's a possibility. Can it be cured? It depends on what's causing the sciatic nerve pain. This one, I think you still need to seek specifically, because it's actually saying that it's nerve pain, knee pain coming from the back. That is a totally different area altogether. You do need to seek professional advice from a back surgeon for that. Does a knee guard help to prevent knee wear and tear? Ultimately, no. But what a knee guard does is it actually helps to give a sensation of stability. It helps to actually at least keep all the parts all running in the correct position itself, so that it doesn't cause a bit of malalignment and load issues passing through different areas of the knee inappropriately. Because sometimes when the patella is actually moving slightly out of position, can tend to cause excessive amount of stress to one part of the knee compared to another part. And that leads on to a bit of faster wear and tear in one area. If it's really, really mainly more of kneecap pain, which is causing, especially when you're going up and downstairs, going downstairs, getting up from a sitting position, getting up from a squatting position, the type of pain itself, then yeah, why not? Getting a knee guard will help, but get a knee guard with a hole in the middle, because it helps. The hole helps to keep the kneecap in position, in the correct position, while at the same time you're not pressing that that kneecap, grinding it against the bone. Okay. How to take care of knees so that it can last until after 85? I would say you have to do cross training. The key is actually not to do. It's not to say that the reason why you exercise and the reason why you do strength training is so as to actually strengthen your muscles and increase your core stability to avoid falls and frailty. But the problem, and also to actually make sure that, of course, there's a bit of aerobics to at least use the system, use the system itself, because absence of use of the system might actually lead on to problems. Anything which is not used will end up with atrophy. So you will need to actually continue to use the system, but it's just not to do it in a constant way with the same activity. There's a need to cross-train and to especially avoid specific activities like what I mentioned previously. Monica Coyle, what do you think of exercise where one is encouraged to stand up from a chair without using hands to support standing? This is a form of strength training for the muscles. That's a good example of strengthening for the kneecaps. How does strengthening leg muscles help the knees? As mentioned previously, it helps to actually align the kneecaps. Also, at the same time, it increases stability of the body so that you tend not to actually fall. And at the same time, right, it actually increases tone around the knee joints so that the knee tends to glide normally in its normal position. What are the statistics of population having knee and hip issues? Well, I would say that it's actually roughly about 10%. It just depends on how bad, how severe it is. Back pain also is 10%. That's the reality. And also it's really down to actually age. Ultimately, everybody is going to get some joint aches and pains down the line itself. My best correlation to this is the idea of white hair. Some people might be blessed with having black hair all the way through to the end of their days, but I can tell you, nah, I don't think so. I think everybody's going to get some white hair, and everybody's going to get a bit of knee pain on and off. The question is, how bad is this knee pain? How is it affecting the person's quality of life? And more importantly is, how is it actually compensated such that it's compensatable enough such that there's an ability for the person to be able to maintain the life which they want to have their quality of life itself. I'm taking sugar-free nanocollagen pure daily. Would there be side effects in the long term? I don't know about that. I have no exposure to this area itself. Ultimately, the best way I can say is this single oil. How should we take care and maintain our knees? I think I've explained that previously. If the plastic fails after 20 years, can it be replaced? Good question. Yes, it can. Now, more important question is, in the process of the plastic failing, has it caused other problems to the knee? For example, like, has the plastic parts worn out with small little plastic particulates such that it caused some inflammation in the knee joint, which leads on to the metal to fail? If that's the case, then you need to replace everything. It's not to say the metal fails, right? The bone around the metal to fail. The bone itself actually starts to become loose. If that's the case, if it's a loose joint, you have to replace everything. Now, at 20 years' time, an important question to find out is, if let's say like it's just a plastic which has failed and everything is still intact, is it as simple as just replacing a plastic? Yes. However, it's actually more importantly, it's availability of the plastic itself. It's the plastic, because at 20 years' time, maybe that model might have disappeared off the shelves or off distribution. So it's important to actually not choose sometimes the latest and greatest, because sometimes the latest and greatest tends to actually suddenly be off the market within about 5 or 10 years, while those which tend to actually be around for at least 10 to 15 years tend to stay. They seem to have lasting power. One example is that the knee implant which I tend to use now has been in the market for 30 to 40 years. Yeah, and with some slight changes here and there, but it allows for new plastic to be placed in, even though it's actually one which has actually slightly different from what was originally implanted. What are the risks for surgery on anemia and blood transfusion? There's not much bleeding for knee replacement surgery. In fact, we don't even do much blood transfusions anymore. We don't even take blood in preparation for blood transfusion procedures. And the majority of the time, the reason why is because the knee joint is actually it's actually, when we actually open up the knee, it's under tourniquet, so there's no bleeding. And when we actually close the knee, we actually make sure we do very meticulous control of bleeding by various means. How long does injection of hyaluronic acid last for? It really depends on the individual because it's down to actually how severe the arthritis is. Just think of it this way. If a door hinge has created a bit of sound and it's not very rusty and you put oil in, you can imagine it should last quite a bit. However, it's a really rusty hinge, one in which you can't even open and close with much ease itself. And it's really creating the loudest sound. If you put a single oil in, you can imagine it might not last too long. So there lies the issue, because there's actually a spectrum of rustiness in a knee joint. So it's really down to how rusty the knee joint is. I think it's the best way of saying it. We're taking collagen help. I would say single oil for a rusty hinge. Why do I experience knee pain when going down slope stairs, but no pain when going up slopes? Is it okay to continue jogging exercise in this condition? There's something to do with your kneecap. The kneecap is wearing out. Please avoid going up and down stairs. Please avoid squatting, standing up. Please avoid getting up from sitting position too often. It's due to the repetition of that. Any recommendations for prevention? Like what I said just now. I need to stretch and crack my knee after sitting a while. Is this regular cracking sound of the knee movement normal? Well, the ultimate truth is, why are you doing it? Because if it's actually to relieve pain, then maybe it's something else. Maybe it's something to actually be worried about, because we should worry about the pain, not about the cracking. But let's say like if you're just stretching and just you routinely crack, this is normal. Why is it a crack sound? Like, when we crack our knuckles, you can hear that sound itself. Well, ultimately what you are doing is you're actually just increasing the volume of the knee joint, or the joint in particular, for the same amount. You're increasing the volume inside of that particular joint, while the same amount of fluids inside, and that reduces the pressure inside the joint. So when you reduce the amount of pressure inside the joint, it tends to cause what we call a cavitation event. The best analogy is shaking a Pepsi Cola bottle really hard and opening it. That's the same thing which is happening in your knee joint while you are actually cracking your knee joint. And that's the reason why you feel that relief after that. That's because there's actually a bubble which has formed inside the knee, air bubble, or essentially a small little air bubble which has formed inside the knee joint. That increases the volume inside the knee joint, and that actually gives a sensation of relief. We haven't figured out how to actually do this reproducibility to everyone. I went for gym tonic exercises and it helped with my knee pain. Why is that so? I'm very sorry. I don't really know what that gym tonic exercises is, but I can imagine it's to do most probably to strengthen and increase the tone of the muscles around the knee. That helps to increase stability and the feeling of proprioception in that area. Is it necessary to take calcium supplements or glucosamine to prevent this? Calcium supplements? No, not really. That's for fractures. Glucosamine, it is actually single oil for the knee. It doesn't actually prevent, neither does it. It's just a bit like a door hinge creaking. We normally don't oil our door hinges routinely, but we only oil it when we actually hear the creak. Same idea here. For rheumatoid arthritis, does it mean no? Rheumatoid arthritis patients, does it mean not suitable for knee replacement? Actually, no. The opposite is true. When rheumatoid arthritis is severe enough until it's actually affecting the quality of life of a patient, we actually do recommend knee replacement surgery for them. However, the risk which a rheumatoid arthritis patient experiences is different, and this one must be specially tailored to the patient. Ultimately enough, the major risk is to do with increased risk of infection and wound breakdown due to the use of pre-existing use of steroids or rheumatoid arthritis medication, and also the increased risk of fractures because most of these patients tend to actually have osteoporosis, either due to the rheumatoid arthritis condition itself, or if not, due to the use of the rheumatoid arthritis medications. But it's still doable, and we still offer. What can cartilage grow naturally? What supplements? Ultimately enough, the key thing to understand is that any cartilage which grows and replaces existing cartilage is actually scar tissue. So the cartilage which we are born with, which is called hyaline cartilage, is actually one which is very tenacious, and it's actually one which is very durable. The scar cartilage which grows to replace it is what we call fibrocartilage, something similar to what you see in the nose. That type of cartilage tends not to actually last too long and tends to wear out quite fast. So that's the reason why most times, right, we have some issues where you can't start thinking along the lines of finding ways and means to use supplements or surgery to actually grow new cartilage itself. Because ultimately, the whatever cartilage is formed is one which is actually not so durable. But I mean, the key is actually to understand what is the end point. If the end point of surgery is to give 100% pain-free experience for the rest of their life, I think that's a bit unrealistic. Well, let's say, like, if it is to say that it is to buy time, to at least, right, reduce pain for X number of years, so that the person can do whatever they want to do until it's painful enough again that they actually will consider a knee replacement, and it is age appropriate at the time to do a knee replacement. Yeah, why not? I think that's a good realistic expectation of any surgery or any sort of treatment for that area. So supplements to grow cartilage? No, not really. My best analogy nowadays is I say all supplements are single oil for the knee. So it doesn't really make the rust less, but it makes the rusty hinge move easier and gets well lubricated. There are walking apps available. App recommends 10,000 steps. Is that too much when there is knee pain? Good question. Ultimately enough, what I recommend is if you start having knee pain, it means that you're doing something too often. And it doesn't mean that 10,000 steps equals to just walking. You can do 10,000, you can also use 5,000 steps with cycling, or you can do another 2,000 steps, right, by just swimming. So in a way, it's what I say previously, cross-training, not to do one particular thing too often, too long. Okay, I cannot actually, can Ambro used for rheumatoid arthritis cause a lowering of the white cells or any other side effects? This one I cannot really comment because I'm not really skilled in the arts of rheumatoid arthritis medication. If pain is on the outer side of the knee, is it a referred pain? Not really. If it's pain in the outside of the knee, the key is whether actually referred pain is when it's actually pain which is not only the knee but somewhere else together with it. So that means pain in the knee together with the calf, or pain in the knee together with the thigh, occurring at the same time. Maybe it's referred pain, and it cannot really localize too easily on the knee itself. If it's localized in the knee, stays in the knee, doesn't move anywhere else except the knee, it's likely in the knee. Does daily application of glucosamine cream on the kneecap slow down the wear and tear process? Realistically, I can tell you, no, not really. One way of saying it is that it actually maybe might help to increase the lubrication in the knee. That's fine. It's just single oil in the rusty knee joint. But the other way is that it actually helps to actually maybe increase the skin condition around the knee itself. That's all I can say about this area. What causes osteonecrosis in the knee? Will TKR help? Osteonecrosis is a very interesting question in the knee. What it's actually saying is that some part of the knee has died off for some reason, causing a little piece of bone to flake off together with the cartilage. And ultimately enough, we don't know why. That's why we call it spontaneous osteonecrosis on the knee. It has no reason. Some people might have a reason. Maybe it's just an injury. But if it's an injury, then we will know it. Most times, we really don't know. Occurs in females who are 40 and above, normally 45, 50-ish. And when it occurs, it acts like a little ulcer, as if like you have actually bitten your lip and you're putting your tongue on the lip itself. That type of feeling. Ultimately enough, these cases, yeah, maybe a knee replacement will help. There could be also other treatment modalities, but most of these other treatment modalities, they don't really give that lasting relief or pain. It really is dependent on the age of the person. So let's say, for example, if it is 50 or below, or 55 or below, normally we will say a bone realignment procedure might be a good idea, because we do need to buy time, to actually to offload the area. Because once you offload the area, there's no pain in the region of osteonecrosis itself. But what's key is buying time, so that you don't need to get a knee replacement surgery done too early in life. Ideally, in my mind, I prefer to do it 60 and above. But nowadays, I think 55 is okay, but 55 and below, not okay to me. Yeah, and it's just that I'm just thinking on behalf of my patients, 20 years down the line. Yeah, when they are older, maybe with more medical problems, and at that time, then needing to do a even larger surgery where I have to extract out the existing knee implant and put in a new one. That's actually a pretty big surgery. I'm actually happy to do that knee replacement surgery. I'm just thinking of everybody, just making sure that they don't need to get unnecessary surgery in the future. The best way I see it is that I always try my best to offer something which is reproducible, and it solves the problem, hopefully once and for all, and it doesn't come back to haunt me or the patient down the line itself. So that's my thinking process for offering knee replacements. Because ultimately enough, some might say just do it anyway right now. But to me, I feel there's a certain time, there's a certain age, there's a certain combination of things which we need. Because it's not only just looking at the X-ray or the pain, it's also to do with function, lifestyle, activities of daily living, quality of life, plans for the future, whether the person is working, whether that job itself is critical, that they are the only breadwinner, and if they cannot work, then they cannot earn money. These patients, maybe we have to do it anyway when they are 50. It's fine, because if they cannot work, that's it. Dennis Wee, what is the best treatment for meniscus tear in both knees of a bow-legged person? I would think the honest truth is really down to age. And the level of bow-leggedness. Younger, then I would say most probably realistically for a bow-legged person, it's actually a bone realignment procedure. If older, then realistically, then I would say it doesn't make sense to do a bone realignment procedure, because the bone realignment procedure is kicking the can down the road. It's a kicking the can down the road procedure. You want to actually then just do once and for all, settle it, and hopefully never touch a knee again forever and forget about a knee and continue on with life. So that's the idea, sir. Yeah. I hope I've answered everybody's questions.
Thank you, Dr. Siow. And I think most of us, really take our legs and knees for granted. And you have given us your extensive experiences with many of the cases you've seen. And I think we answered most of the questions, those common ones. And I really appreciate the time they've given to all of us today. You have a good weekend.